Hi, Nutrition 111 students. Let me share screen and we'll get started with chapter 3. So this chapter covers the human body, and it really is a review, perhaps, of a good bit of anatomy and physiology that connects very closely to this course. You know that A&P 1, Biology 109, is a prerequisite for this course. And there's a good reason for that. We talk a lot about anatomy and physiology. In this lecture, I'm going to focus in on digestion. You are what you eat is a saying that we use quite a lot, but biochemically it is true. What we take in through our diet is broken down into smaller components that our body uses. I want to show you, and I'm hoping the quality is okay, a quick video that is taken with an internal camera that shows you some of the digestive process. We'll move through the digestive tract.
A new camera shows a high-definition view of how food travels through our bodies and into our stomachs. Food enters the stomach through a hole at the top. The stomach is a bag of muscle that churns, squashes, and squeezes food into liquid. At the same time, acids break the food down. The stomach walls protect themselves with a lining of mucus. Without it, the acids could digest parts of the stomach itself, causing stomach ulcers. About an hour later, the stomach squeezes the broken down food out through a tiny hole called the pyloric sphincter. The food enters the small intestine, an 11-foot coil of tube where we absorb most of the nutrients. The interior wall of the small intestine is lined with millions of microscopic projections called villi. These increase the surface area of the gut, making it easier to absorb nutrients. First, the pancreas pumps out a juice that neutralizes stomach acid. Then bile from the liver breaks down the fats into tiny droplets. Smaller droplets are easier for the intestine to absorb. After an hour and a half, the small intestine has absorbed most of the nutrients from the food. It's time for what remains to move on. It enters the large intestine through this, the ileocecal sphincter, a valve that keeps our food from going back where it came from. What's left is a mix of waste food and dead cells from the walls of the gut. The large intestine's main job is to extract water from it. Lots of bacteria live here too, but it isn't because of an infection. We actually need them. They produce enzymes that break down complex carbohydrates in our food, carbohydrates we couldn't otherwise digest. Finally, after about 12 hours, we expel what's left of our first meal.
So we did lose some of the quality there, but I think the narration is very important because it leads us through this process of digestion and absorption, breaking down and absorbing from the digestive tract into the circulatory systems. Your textbook goes into much detail. I think it's important that you review all pieces of this figure 3.9 because this will supplement the quick video we just looked at in terms of each part of the intestinal tract and also the organs that are accessory organs. They provide secretions, enzymes, bile that is needed for digestion. Let's start with the swallow, however, because this is where it all begins. The salivary glands do secrete saliva, which does have an enzyme to break down a little bit of carbohydrate. And we see here the process of swallowing. You may notice that the passageway to the stomach is perilously close to the passageway to the lungs. And we have a little structure called the epiglottis that should close over the larynx, so the food will move into the esophagus instead of into the trachea. Okay, that is the role of the epiglottis, very, very importantly. The swallow is mechanically complex. A lot of different muscles are involved. And for a number of different reasons, people can have problems with swallowing. This is called dysphagia or dysphagia. Here are some of the symptoms. Now, you may notice these symptoms in long-term care, in home care, certainly in hospital care as well. What you're seeing are problems with the swallow. Very commonly, things like pocketing of food, incomplete swallows, a gurgling or raspy sounding voice after eating, needing to swallow more than once, coughing or choking while eating is another sign. The problem with dysphagia is it can lead to aspiration, the movement of substances into the lung, and then aspiration pneumonia, which can be very dangerous for compromised patients, for elderly patients, for patients who may be disabled. So if you notice the signs or symptoms of dysphagia, you call up the expert, and that expert is the speech pathologist. The speech pathologist is also an expert in swallowing and will do a swallowing evaluation of your client. Part of that evaluation may be a video study. So let's look at this really quickly. You're going to see
on March 16th,
and hear
2021, 6 women were among the victims of a horrific shooting in Georgia.
It's fine, but then all of a sudden, and even when you said, Dad, I hope she does it today, that's, sometimes that can happen with our swallow study, depending on if our radiologist didn't feel like fluoroing as much as we did today, would we have totally missed it,
I knew she gets
there it is.
There it is.
Yeah, it was also before the swallow. So what's ending up happening is...
It's real obvious.
Yep. A little bit of the liquid. So right here is our, it's called the vallecula. It's just kind of like a little pocket. And then we've got another little pocket, the piriform sinus, lower down here. And so it starts to spill over the vallecula toward the piriform sinus.
Right in the airway.
Yep, misdirected right into the airway. Yep. No cough response, no choke.
Okay. So that is one of the tools that we use to diagnose dysphagia and aspiration. The speech therapist will also design a plan which might involve thickening of liquids and may involve modification of the consistency of the diet. Thickened liquids are easier to control than thin. But the problem with thickened liquids, there are different levels of thickness. Thickened liquids aren't as refreshing. They aren't as desirable. So you need to watch your clients who are receiving thickened liquids to make sure they don't become dehydrated. Now, you may think that every client with dysphagia has to have a pureed diet, but this is not true at all. You need to wait for the assessment from your speech therapist. You may put them on a pureed diet temporarily, but that assessment could show that they can have soft foods or ground foods with gravy. The problem with pureed is without any texture, some patients lose their appetite. Now, this is what I call old school pureed because it's basically just ugly lumps. We now have molded purees, which are much more aesthetically pleasing. We eat with our eyes, so this is something that is preferable. Remember that upon the swallow, after the food is swallowed, peristalsis takes over. Peristalsis are muscular contractions that propel food down the GI tract. And the next organ that is reached is the stomach. The stomach is very muscular. The stomach also is very acidic in terms of its contents, as it's meant to be, because that acid kills off germs. That acid helps digest food. It's necessary in digestion. The stomach is coated with mucus so that the walls are not digested by that acid. In some cases, we have what's called GERD, gastroesophageal reflux disease. And this is when we have acid reflux past a relaxed esophageal sphincter into an esophagus. And this can cause pain, discomfort, a kind of icky taste. And it can even scar the walls of the esophagus, and in a worst case scenario can lead to a precancerous condition called Barrett's esophagus. So we need to manage acid reflux when it is more than an occasional problem. This is a look at an ulcer. And we see in this ulcer that there's an erosion of the wall of the stomach. Ulcers come about for a number of reasons, but the most common reasons are an infection with a acid-resistant bacteria called H. pylori. Okay, that is one, and also taking medications that decrease the mucus which protects the stomach. Other things like stress and cigarette smoking, other medications can be contributing factors as well. Now, this is a side-by-side chart that shows you the nutrition and lifestyle recommendations for care of heartburn and peptic ulcers. For both, you want to eliminate things that can, of course, worsen the condition. So it is helpful to eat smaller meals, to limit alcohol and other substances that can be irritating. You'll notice with heartburn, we also think about the mechanics of more pressure on or in the stomach, increasing the pressure on the valve, the lower esophageal sphincter. So things like avoiding tight clothing, not lying down for a few hours after your last meal, elevating the head of your bed, that becomes important with GERD, with gastroesophageal reflux disease. I'd also mention that some substances specifically loosen that sphincter that should be holding the acid in the stomach, and they include peppermint, spearmint, and chocolate. So sometimes people recommend a mint for any digestive problems, but a mint could make GERD worse, not better. So read over these recommendations. The small intestine is where most digestion and absorption takes place for very good reason. We have secretions from the pancreas and the gallbladder from the liver. We have enzymes that are secreted on the surface of the small intestine and a tremendous surface area because of these folds of the small intestine and the villi. We also have the circulatory systems that sit right beneath the cells of the surface of the small intestine. So in a healthy individual, you don't have to think much about digestion and absorption. Your small intestine is doing the work. I mentioned the accessory organs, but I'll mention them again. The liver produces bile. This emulsifies fat so it can be digested. And the liver sends this to the gallbladder, if you have a gallbladder. If your gallbladder was removed, then your liver sends it straight to the small intestine. You also have the pancreas, which produces pancreatic juice, and this neutralizes the acidic content that comes from the stomach. After the small intestine, the waste moves through the large intestine where water is reabsorbed, the waste becomes more solid, and some salts are reabsorbed as well. Now, this is where we talk about the importance of a healthy intestinal microbiota. We've got healthy bacteria that live in our GI tract that influence everything from our mental health to our physical health. And you will take a look at this in one of your discussions in Unit 1. We know that many changes in the way we are living has altered the gut environment to one that is less healthy for us in terms of fewer healthy species of these microorganisms. So what can we do? We can eat foods that nourish those microorganisms. They are called prebiotics. They tend to have a lot of fiber. Those microorganisms digest the fiber. And we can also consume foods with healthy bacteria in them, and those would be probiotics. A couple of problems that can occur in the colon. In diarrhea, waste moves through too quickly and not enough fluid is removed or fluid is added because of an illness. And the main concern is dehydration. So we need to make sure that people are well hydrated with something that's not high in sugar, something like Pedialyte for children. And diet is allowable. It's best to keep it to mild foods, not too much milk because that can irritate things, and certainly nothing that is very, very spicy while you're having a diarrheal illness. In constipation, things move through too slowly, and then bowel movements become difficult. The advice is to drink more fluids, eat more fiber, and get regular exercise, and only use laxatives if they're prescribed by a physician, because they can cause some dependency issues if they're not managed properly. Irritable bowel syndrome is very common as well. This tends to cause bloating and pain, diarrhea, perhaps constipation. And we found that what's called the low FODMAP diet can be helpful for some individuals. Others just need to find out which foods are triggers. But you may hear about FODMAPs and the low FODMAP diet. This is limiting fermentable carbohydrates that end up in our bowel, causing a bit of problems for these patients with irritable bowel syndrome. The rest of us don't need to avoid them, but those who have IBS might want to try avoiding foods that are higher in these FODMAPs. Gallstones, okay, for another problem that's not uncommon. We tend to get a lot of pain especially after fatty foods, since the bile is important for fat digestion, and that's an unbelievable picture of a gallbladder with gallstones, isn't it? If you can imagine that your gallbladder is filled with these stones and it squeezes as the hormones from the small intestine signal for it to do, that really does cause pain. And the treatment is generally removal of that gallbladder. Finally, celiac disease. This is a chronic immune-mediated disease, and it's caused by gluten. Okay, so it's a problem caused by gluten in certain genetically predisposed people, sorry, found in wheat, rye, and barley, and impacts about 1% of the US population. We have kind of two sides of the coin here. Some people with celiac disease are putting up with the symptoms and don't know the cause. Other people are putting themselves on gluten-free diet without a real cause. So there is an indication of a gluten-free diet for those with celiac disease, because when someone with celiac disease consumes gluten, their small intestine flattens out and their absorptive capacity decreases tremendously. And this causes all kinds of nutritional and other problems. When they cut gluten out of the diet, their small intestine does bounce back to normal. It's very important to remember, however, if you have a client who fears he may have celiac disease, he or she should get tested for it before they go on the gluten-free diet, because the gastroenterologist needs to take a look at the small intestine on gluten. There are some individuals, like my daughter, who have what's called a non-celiac gluten sensitivity. And what this is an intolerance to gluten that isn't celiac. It can cause a lot of different problems, and it's alleviated by elimination of wheat, rye, and barley. So that is our chapter 3, end of unit 1. Take care, everybody.